Usually, when you look at a massive structure like a skyscraper, you assume the foundation is solid.
Right, until you zoom in and see hairline cracks.
And that's what the US healthcare system looks like right now. We're using the August 2026 SWIFT Healthcare Intelligence Brief to show where the concrete is splitting without turning this into a textbook.
And the big takeaway is that affordability is no longer just a pricing problem. It's fragmenting the insurance market itself. People and businesses are changing how they participate because the old math has stopped working.
You can see that in the small group market. Insurers are requesting a median 14% premium increase for 2027.
Most are between 10 and 20%. 6 insurers are asking for more than 30%.
Which can wipe out a small company's profit margin in a year.
And it's not just hospitals charging more or specialty drugs costing more. The brief says administrative friction is now part of the inflation story.
Meaning what exactly?
2 United Healthcare filings in New York attributed 0.8% of their 2027 increase strictly to the arbitration economics of the No Surprises Act.
So the cost of arguing over an out-of-network bill is itself raising premiums.
Exactly. If you're paying arbiters and lawyers to settle a $2,000 dispute, and that process creates $500 of overhead, that friction gets baked into next year's premium.
The system is getting more expensive just to manage itself.
Yes, and that pressure is helping break apart the risk pool. Fully insured small group enrollment fell from 17 million in 2013 to 10 million in 2024.
7 million people out of the pool.
Mostly not disappearing. Healthier businesses are moving to level-funded plans.
Because they don't want to keep subsidizing sicker groups in the community pool.
Right. They pay a steady monthly amount, take on some calculated risk, and may get a rebate if claims come in low.
It's the dinner party problem. The people ordering tap water and a salad get tired of splitting the check with the steak and wine table.
Exactly. In actuarial terms, risk pool deterioration. Once the healthier groups leave, the remaining fully insured pool is sicker and more expensive. That pushes premiums even higher and drives the next healthiest group out.
So the traditional pool gets hollowed out.
And the patients leaving commercial coverage don't land in a stable backup system. Medicaid and the ACA exchanges are both seeing enrollment drops.
Quick caveat, when we talk about Medicaid work requirements, we're not taking a political position.
Right, we're looking at the structural math in the brief. If states require people to document 80 hours a month of work, school, or volunteering to keep coverage, the practical result is more uninsured people.
Nebraska is already terminating coverage for people who don't meet the requirement.
And projections suggest up to 7 million people could eventually lose Medicaid coverage nationwide.
Then on the exchange side, enhanced federal subsidies expire, people do the math at the kitchen table, and some drop coverage.
February enrollment fell to 19.2 million, down 12% year over year. And insurers say the healthier members are the first to leave.
Because they think they can risk going without coverage.
Right, but the care need doesn't disappear. It shows up later as uncompensated care.
And hospitals eat that.
They do. Universal Health Services said the drop in ACA enrollment is effectively a one-for-one move into uninsured status. HCA raised its 2026 bad debt estimate because of the payer mix shift to between $1 billion and $1.2 billion.
$1 billion in care they don't expect to get paid for.
And hospitals operating on 3 to 4% margins can't absorb that, so they go after the one place they still might recover revenue, commercial insurers.
Which is why these contract fights are getting ugly.
The brief highlights the dispute in Virginia between Sentara and Anthem. Sentara is threatening to let contracts expire, disrupting in-network care for nearly 380,000 members.
And the negotiating gap tells the story.
Sentara wants a 6.2% reimbursement increase to cover labor and bad debt costs. Anthem countered with about a 1% decrease, arguing employers can't absorb more premium hikes.
7-point spread, that's huge.
And it's not just future rates. Sentara says Anthem owes $105 million in billed charges over 90 days old, a $12 million prior settlement, and they're also fighting over $4 million tied to emergency department coding downgrades.
When multi-billion-dollar organizations are fighting over $4 million in old ER coding, the math is bad for everybody.
That's the point. Claims payment, coding disputes, and reimbursement administration are now as contested as fee schedules. And employers in concentrated hospital markets should notice something. The discount they think the insurer won for them only matters if the insurer is actually willing to push a dominant hospital out of network.
If the insurer blinks and pays the 6.2%, that shows up in employer premiums next year.
Exactly. It's a game of chicken.
Now compare that with Medicare, biggest payer in the room, and using a mix of carrots, sticks, and audits.
The carrot is a 2.3% hospital payment increase for 2027, about $2.1 billion more in reimbursement.
And the stick?
The mandatory CRJX joint replacement model. Hospitals become financially responsible for the full episode of care around a joint replacement, not just the operation.
So recovery, physical therapy, post-acute care, even complications.
Right. If the patient gets an infection and comes back to the ER, the hospital bears that cost. CMS projects $725 million in Medicare savings over 5 years starting in 2028.
They're pushing complication risk onto providers.
At the same time, they're auditing documentation. There was a $14.1 million settlement over allegations of unsupported diagnosis codes submitted from 2020 through 2023 in Medicare Advantage.
Because risk score inflation is a major hidden cost driver.
A plan can add a severe diagnosis from a vague chart note, make the patient look sicker on paper, and trigger thousands in extra federal payment without more care being delivered. CMS is clawing back.
And they're also tightening payment for new technology.
By fiscal 2028, Medicare will remove automatic extra payments for FDA-designated breakthrough devices. Novelty alone won't do it. Manufacturers have to show substantial clinical improvement or distinct economic value.
So Medicare is saying, we'll give you a 2.3% raise, but we're auditing coding, shifting episode risk to you, and we're not paying extra for shiny hardware unless it proves itself.
That's basically it.
Commercial employers don't have that kind of leverage, especially with GLP-1 demand.
No, this has become a CEO-level issue. Bank of America's CEO Brian Moynihan said they're spending more than $250 million a year on GLP-1s for 210,000 employees.
1/8 of a $2 billion health budget on one drug class.
And many employers can't do that, so some drop coverage for GLP-1s entirely.
But demand doesn't vanish.
It reroutes. The brief says CVS is building a cash-pay GLP-1 channel with Eli Lilly across 9,000 locations, connecting self-pay patients with prescribers through Minute Clinic outside the traditional insurance benefit.
And it's paying off.
CVS's pharmacy and consumer wellness segment saw second quarter operating income nearly double to $1.4 billion.
So pharmacy is building a bypass around insurance.
Yes, and that creates a blind spot. If a patient buys a GLP-1 with cash and later avoids a heart attack, who gets credit for the savings? The employer might benefit if the patient stays on the medical plan, but the employer's care coordinators may not even know the person is taking the drug because it was a cash transaction at CVS.
So we're seeing medical to pharmacy cost migration.
Exactly. And it spills over elsewhere. Hinge Health bought Cylinder Health for $105 million to move into GI care, specifically noting that GLP-1 use is driving gastrointestinal side effects and employer interest in managing those costs. The brief also notes GI conditions already cost the system $135 billion annually.
Which also explains why employers are tired of buying separate point solutions for every body part and symptom.
They want consolidated platforms that manage multiple conditions in one place.
Now let's talk safety nets, because those are fraying too.
A big one is the 340B drug pricing program. Manufacturers provide outpatient drugs to eligible safety net hospitals at steep discounts. Hospitals buy low, bill commercial insurers at standard rates, and use the margin to support uncompensated care.
And it's large now.
$100 billion in purchasing by 2025. The brief says a bipartisan Senate bill would reshape that cash flow with a third-party clearinghouse to track duplicate discounts and stop a planned HHS rebate pilot.
And the mechanics matter. Upfront discount versus back-end rebate is not a bookkeeping detail.
Not at all. If hospitals have to buy at full price and wait for rebates, that creates a major cash flow crunch for facilities already operating on razor-thin margins. Hospitals see that as potentially catastrophic. Manufacturers want the clearinghouse to stop what they view as duplicate discounts.
Meanwhile, rural infrastructure is already cracking.
Sturgis Hospital in Michigan closed even after converting under the Rural Emergency Hospital model. More than 1,700 hospitals are eligible for that model, which offers enhanced Medicare payments in exchange for closing inpatient beds, but only 50 have converted.
Because administrators don't think the rescue model is enough.
Right. And again, just looking at the math in the brief, federal Medicaid changes are projected to reduce funding by more than $900 billion over 10 years. There's a $50 billion rural health transformation program meant to offset some of that.
But 900 billion in cuts versus 50 billion in support is not a close call.
No, and the early warning signal is that rural provider instability tends to come before claims inflation.
Because when a rural hospital closes, patients don't stop needing care. They drive to the regional system.
And that surviving system gains market power, pushes insurers for higher rates, and eventually those costs flow back to employers as premium increases.
Which brings us back to the opening image. The foundation cracks, the weight shifts, and the whole structure groans.
That's the story. Affordable coverage is cracking. Healthier businesses move to level-funded plans. Some consumers bypass insurance for cash-pay GLP-1s. The sicker population gets concentrated in shrinking traditional pools. Hospitals lose revenue from Medicaid and exchange erosion, then push harder on commercial payers just to stay afloat.
And if employers and patients keep routing around the traditional benefit, you can see where this goes. More direct relationships, more subscription-like models, hospital systems and pharmacy chains taking payments more directly, with insurance cut out of more transactions.
At least worth thinking about the next time you look at the deduction on your paycheck.
That's it for today.
Keep looking beneath the surface.
We'll see you next time.